A very good afternoon to everybody. This is Dr. Anjali Agarwal. I'm presenting India uh, in the EDS Society conference. So today I'll be talking about managing postpartum prolapse. Myself, a little introduction about myself. I'm a consultant physiotherapist, women's health specialist, lifestyle consultant. I also do telehealth rehabilitation, and I'm the advocacy co-director for Long COVID Physio worldwide. So going to the deep of the details of myself, I practice in a city called as Hyderabad, which is in the south of India. I do telehealth rehab for most of my patients with pain management, and I treat a lot of musculoskeletal disorders, cardiopulmonary ailments like COPD, asthma. And I'm so treating long COVID physio now through telehealth rehab. And a lot of women's health issues like prolapse and diastasis, pregnancy care, and also represent the EDS Society of UK and India. I've also been treating EDS, spots, MCAS, and hypermobility. And being an advocacy co-director long COVID physio, I do a lot of advocacy for long COVID so that the vulnerable population around the world stay safe and they practice a safe practice of care for themselves. So I've been trained in the UK and India, and at present I'm working in India. I've been a graduate from one of the world's most popular college called SSKM College, IPG Mayar, Kolkata. I did my further training in heart manual training with NHS Lothian in Entry Day Hospital, Edinburgh. So a major part of my practice was also in UK, in London. I've been the advocacy for physical literacy program, which is run by a badminton academy in India. I've been a convener for health and well-being, CII, IVEN, Telangana, 2018 to 2019, and co-convener 2017 to 2018 in India. Let's now dig deeper into the topic of postpartum and how do we deal with it in cases of EDS. Let's bounce back managing postpartum prolapse in cases of EDS. So we'll run through a little bit of introduction as to understand what do we mean by postpartum prolapse, reasons and symptoms of it. Then we also go on to managing postpartum in EDS, childbirth methods leading to what are the childbirth methods which are actually causing EDS patients to have not good results after giving birth. Preventing postpartum prolapse is also one of the biggest preventive goal for us, and also supporting women with postpartum prolapse in case of the EDS, which should be a teamwork. And lastly, we'll conclude with our key points. Now, let's understand that the prolapse is a common condition which any woman after having a childbirth may have. But women with EDS or Ehlers-Danlos syndrome have to have a very challenging time when they give birth. Most of them, they have it. About 95% of my patients would always report some kind of a lingering issue because of a prolapse after childbirth. EDS is a genetic disorder. And most of us, we know that the connective tissue in the body, which involves also the pelvic organs, is also affected. And this can lead into a higher risk of prolapse and more other pelvic floor disorders. Most of the women with EDS would complain of pregnancy, which is not so smooth. They would always complain of pelvic girdle pains or SI joint pains, or they dislocate the hip joints or the SI joints quite frequently during the pregnancy. So the same thing almost happens when they are giving birth. And the kind of birthing methods or the childbirth methods we choose for these women is so very important because we need to minimize any trauma during the childbirth period. Let's understand what the prolapse means. Now, the child postpartum prolapse can be occurring in the pelvic organs, such as the uterus, the bladder, the rectum, which slips out of place and descends into the vaginal canal. Now, this can cause a variety of symptoms, which could be pelvic pressure, Then people feel a lot of pain in the pubic area. Then there's discomfort during sex. Urinary and bowel incontinence is the most common symptom which most women report, and then they try to seek help from pelvic floor physiotherapist and women's health physiotherapist. Constipation also marks about 50% of the women complaining post their delivery, and coccydynia or the tailbone pain. So during the time of delivery, sometimes the child may come out so smoothly because of the spontaneous delivery, which is very common in EDS, that they try to push away the tailbone sometimes, or there could be a tailbone fracture, which might cause a coccydynia or a tailbone pain. Now, what happens during the childbirth, especially when we are looking at vaginal birthing? It can deliberately cause a lot of cervical defects in cases of EDS. And most of these problems come because of overstretching of the cervical tissue. And despite the absence of any defect, this might indicate that there might be long-term complications which can cause cervical stenosis and incompetence of the cervical region. In the future pregnancy, therefore, increased surveillance is obviously very much required so that we can reduce the chances of cervical incompetence, such as shortening and funneling of the cervix. The mode of delivery in cases of EDS patients' pregnancy should be based on obstructive indications, concomitant consideration of the index of cervical trauma. So our goal has to be preventive. Our goal has to be always keeping in mind what is coming before our eyes during the time of the delivery process. If we feel that the woman is entering into a phase where she might enter into a difficult labor, we should switch sides and take a very, very important decision of childbirth. The understanding of the vaginal birth following the previous cervical trauma is a always known clinical practice. Additionally, there are reports of vaginal birth in women who had prolapse during labor. So many of the women during the time of labor would have ended up having a prolapse there and then. However, some clinicians do recommend elective cesarean delivery for the next pregnancy following a previous prolapse or cervical trauma. So many times it's important for the gynecological societies to be raising this awareness. Why are the women having a lot of issues when it comes to pregnancy and childbirth? We have to look at issues where these women are being not ruled out for EDS. So if these women are being ruled out for EDS, we need to make sure that we are trying to give them the right advice. Now, childbirth can give us a very big award, is the incredible gift of children. But changes to the body can linger after a little one has grown up. So many of the women may have casualties or damage their pelvic floor organ. This happens with every woman. The group of muscles, ligaments, and tissues do a hard work supporting the uterus, the bladder, and the rectum. But keep in mind that these muscles, with enough wear and tear, they can get weak. And when these muscles weaken, things start to drop. So they are like a hammock. And this hammock's job is to support the organs. They're supposed to not let these organs fall down. But in cases of EDS, this is the tissue which is a weak link. And that lets any kind of trauma or childbirth process which has not gone right to have a more traumatic effect on the pelvic floor. Now, this causes the uterus bulging down into a vagina, which is called as prolapse in normal cases. But in cases of EDS, the pelvic floor and the birthing practice, a lot of care has to be taken in terms of handling pelvic floor during normal delivery. So a lot of awareness has to come among the gynecologists, and they should be understanding the role of there is very prime in understanding and sending these women for checkups and identifying that these women are having EDS. Many women who go into labor, distress labor, they have hypertonic pelvic floor. By default, we know most of the pelvic floor disorders in EDS women starts from the time they enter puberty. So many of them, they already have a hypertonic pelvic floor, not letting labor to progress. In many cases, interventions like forceps use can cause further damage to the pelvic floor, resulting in prolapse. So the women have to talk about this to the gynecologists, and the gynecologist and the physiotherapist who's dealing with pelvic floor rehab should be aware of EDS patients. And there and then, when this delivery is happening on the table, many of these women get diagnosed. So that is the unique part of understanding how EDS women can, behave at the time of delivery. Long, difficult labor usually is the culprit sometimes. We always say that that is the reason a woman has ended up into having these kind of problems. Although difficult labor that involves breech births, extended pushing, deliveries that require forceps, vacuum pumps, proves stressful for the pelvic floor, structures prolapse can start long before. So prolapse could have started long before the childbirth process, but all these delivery methods that we use for EDS women can sometimes cause major complications. Delivery with pregnancy itself, cases of genetically weak tissues in EDS. Now, the pelvic floor, let's look at the pelvic floor. You can see the structure of the bones here, the muscles attached to the tailbone and the sacrum, and also around the pubic bone. So the pelvic muscles are a bowl. They're just like a bowl which cradles the bladder, the uterus, and the rectum. If the prolapse occurs in front wall, then the bladder can sag. In the wall supporting the top of the vagina, then the uterus sags. In the back wall of the vagina, then the rectum can sag. And at the end result is that it creates a bulge in the vagina. So now, simply carrying a pregnancy does a lot of strain for just a simple case where there is no EDS. So supporting the structures of the vagina and the pelvic floor, that sets the stage for prolapse for the future. There is a myth that C-section can prevent pelvic floor disorder for women with EDS. Having a C-section doesn't protect or from prolapse or urinary incontinence. You are at the mercy of many other factors as well. So the factors could be the posture, could be the way a person carries and walks around, the gait patterns. That's when podiatrists come into picture. It's a carrying of the baby, which the genetics say, and the bad luck at play. That's because the genes can determine the muscle and the strength for the women. Born with weaker tissues are at a greater risk for prolapse, as been reported by the American Urogynecological Society. Now, the classification of the prolapse can be grade 1, when the inverted fundus up to the cervix has come down. Second degree, body of uterus reduced to the vagina into the cervix. The third degree prolapse is inverted uterus outside of the vulva. Managing of prolapse, so postpartum prolapse in EDS, requires a comprehensive approach that should address the underlying condition and the prolapse itself. So that means women who have EDS needs to be supported during the pregnancy time, during the time of conception, during the time of puberty, during the time of the teenage years, so that they don't end up having a prolapse first and for all. This can include pelvic floor physiotherapists by informed physiotherapists who are informed into EDS, informed about hypermobile tissues. Exercises to strengthen or relax the hypertonic pelvic muscles, or surgical interventions if required. So we have to give them the choice. We have to give them the right information so that we can educate women right from the time they get pregnant, right from the time they're planning their conception also. The preventing postpartum prolapse can also mean that we prevent the prolapse in EDS. There are steps that can be taken to reduce the risk. First is to have a healthy weight and also avoid heavy lifting. There's a proper technique of lifting that could also help them. Avoiding strenuous exercises and also straining while avoiding and being constipated. Practicing good posture and practicing good biomechanics. So it's important that the way people stand during pregnancy, sit during pregnancy, evacuate during pregnancies are so important. And at the same time, it's important from the growing years, these girls, these women are being taught about safe practices so that the future is not so, cumbersome for them. If we look at the pregnancy posture, Many times these postures can change because of the effect of the growing weight of the baby. Many times because of lordosis, the increased curve at the back of the spine causes a protruding belly. And for many of the women with EDS, this causes a disbalance in the center of gravity. And that causes a lot of anterior pelvic tilt, which they always have by default. And that can cause a lot of pressure down the pelvic region. So majority of the prolapse starts when the woman is already delivering or is already pregnant. Then there is also a time when the woman delivers the baby and tries to hold the baby. She holds the baby, the third picture where the forward shifted pelvis or the sway back. Many of the women after delivery go into that kind of position, and that causes a more further loading of the pelvic floor because their pelvic weight shifts and the hip joints hyperextend, the knee joints hyperextend, which in many women is already there with hypermobile joints of the knee, which causes further damage to the pelvic floor, more pressure on the pelvic floor organs. Now, the key thing to remember in many of these situations are how do we maintain their posture? How do we take care of their, sitting posture and biomechanics? Now, following a safe regime of exercises should be aimed and should be goal at balancing, relaxing, equally strengthening the pelvic floor postpartum for EDS and should be patient specific. Not doing Kegel, which is routinely being advised in the gynecological rooms, should be a blessing. Two, in case of EDS. Many of these women have a tightened pelvic floor, and if we tell them to do Kegels all the time, that can be detrimental for their prolapse. So, among the pictures we see, there are several exercises which are being seen here. But as I said, everything has to be under somebody who's more advancedly trained into pelvic floor and also understand it's important to be under the guidance of somebody who knows about EDS. This is me. I do a lot of telehealth rehab for my patients, and I've got a permission because these women want an answer for their problems also. So they want to raise awareness for all of you. And the tailor-made telehealth rehab exercises, the pelvic floor rehab and EDS in postpartum has to be tailor-made. So we see a lady has been lying on her left side, and sometimes the uterus can shift either to left to the right. And accordingly, we kind of do our physio management online for these women also. We can do it in so many surroundings and help these women get a very good pelvic floor, and damage can be avoided. And also rehab can be done for these women. The biomechanical changes, as you can see in my patient's picture here, she also having a flat foot. So both of her feet on the ground, the podiatric help would have helped her during the pregnancy or during the pre-pregnancy time. But I think it was late when she came to me. She's come to me postpartum. That's when I identified and I diagnosed her for EDS, because many of these women didn't understand that EDS was the situation, why their pregnancy was so painful, or why was the hip slipping out, or why were they dislocating so often. Now, the biomechanical change we can see is one side of her body shifted from the center of gravity. Her feet is flat and protruding belly in forward, and her butt is kind of hyperextending, or the hip is hyperextending. So this kind of called as a sway back. And these women then tend to complain of tightness in the pelvic floor. They feel a bulge down their pelvic floor. And that's when we kind of help them, especially considering EDS. And another case of my patient is about a bulging belly, which is also called as a mummy tummy or the diastasis recti. Now, most of these moms would have diastasis recti in pregnancy only. They would have it as a puberty enters. They might have it as a kid. They might have it as an adult or a young girl also. But pregnancy hormones again causes hypermobile tissues to kind of deviate or separate out, and the muscle of the tummy just separates out, causing diastasis recti and increased chances of hernia. And most of these women who don't get that diastasis treated end up with prolapse. So everything is together. The muscles of the tummy, the spine, the pelvic floor, they work like a canister and they are supporting each other. So if the spine is not stable, the tummy is not stable, tummy being not stable, the pressure of the organs go onto the pelvic floor. So look at all these variety of things which we can deal with during the pregnancy and avoid these kind of problems for these women. So let's understand supporting women with postpartum prolapse in EDS. It's important for every healthcare provider understand the unique challenges faced by women with EDS who experience postpartum prolapse. This includes providing education, resources, support to help them, and also manage their condition and improve their quality of life. So we will have to get this word out to the gynecological chambers and make them understand that 1 in 3 women might have EDS, what to look for, how to prevent further damages during childbirth. Thank you, everyone. I've come to the end of the session, and that's my contact details. If anybody wants to, post a question or ask me any kind of, questions they have, and they can reach out to me on my mobile numbers. I'm in India, so you would have to put a code 0091. Thank you, everyone. So the conclusion of my talk is, please understand that we have to manage prolapse. We also have to manage the underlying problem which